Hello everyone, welcome to this session on general anesthetics. In this session, we will talk about what are general anesthetics, what are the properties of general anesthetics, how they act, what are the various drugs that are used as general anesthetics. We'll compare these drugs and talk about the advantages and disadvantages of each one. And we will end the session with short notes on conscious sedation and pre-anesthetic medication. So what is general anesthesia? General anesthesia is a drug-induced reversible loss of consciousness and all other sensations. So the important points here are the words drug-induced, meaning to say that this is a loss of consciousness which is induced by drugs, that is not naturally occurring, and they're just not as loss of consciousness with all sensations are also lost, and the most important point is that all this is reversible. So anesthesia comprises of the following points: there is reversible loss of consciousness, there is reversible loss of sensation, there is analgesia, that is during the period of anesthesia the person is not able to feel any pain. There is amnesia, that is the person is not able to remember the things that happened during the period of anesthesia. And there is muscle relaxation and abolition of all reflexes. Thus, general anesthesia is a combination of these four important features. Now, how do general anesthetics act? Now, before that, we have to know that there is a particular part of the CNS called reticular formation, which maintains a state of consciousness of the body. Therefore, general anesthetics act by depressing the functioning of this reticular formation. Now, the depression of the reticular formation can be by two methods. One, you either increase the activity of inhibitory transmitters like GABA. So GABA is an inhibitory transmitter which depresses the functioning of the central nervous system. So we can either increase the activity of GABA, or we can block the activity of excitatory transmitters. That is, example for an excitatory transmitter is glutamate. So what general anesthetics do is they depress the functioning of the reticular formation either by increasing the activity of inhibitory transmitters like GABA, or by reducing the activity of excitatory neurotransmitters like glutamate. Now, before moving on to the various drugs that produce general anesthesia, what are the various stages of anesthesia? So the first stage is the stage of analgesia. That is from the beginning of anesthetic inhalation till the loss of consciousness. So that period is called as the stage of analgesia. The second stage is called the stage of delirium. So we have seen till now that what general anesthetics do is they reduce the activity of the brain. However, before doing that, there is a short period called the stage of delirium wherein the CNS is excited. So there is excitation, there is rapid, irregular or jerky breathing, and there is sympathetic stimulation which leads to increased heart rate and increased blood pressure. The third stage is called the stage of surgical anesthesia. This is the period where most of the surgeries are carried out. So in this stage the respiration is regular and the sympathetic stimulation also comes back to normal. The final stage is called the medullary paralysis, wherein there is cessation of breathing, breathing stops, there is failure of circulation, and this can lead to death. So the anesthetist's job is to keep the patient in the stage of surgical anesthesia. Less than that will have its complications. More than that, if the patient goes in for medullary paralysis, can lead to death of the patient. Another thing that we have to remember is these stages of anesthesia are clearly delineated, or they are clearly spaced in case of ether used as a general anesthetic. So with ether, we can clearly see these 4 stages of anesthesia. However, in modern anesthesia, with most of the drugs, there is no clear limit between the stages. That is, one stage slowly eases on to the other stage, so you cannot exactly make out the difference between one stage and the other. As I said, there are no clear-cut stages seen with the use of the modern general anesthetics. Along it also, these stages have been removed with the use of pre-medication and when we give too many drugs together. Now, what constitutes an ideal anesthetic agent, or what are the properties of an ideal anesthetic agent? The first thing is the drug should be pleasant, non-irritating. It should have a fast induction and fast recovery. This holds especially true when we are using gaseous agents or inhalational anesthetics. So while inhaling the drug, it should not produce any irritation in the nasal mucosa or in the nasopharynx. And another important property is the anesthesia should happen fast, and the recovery from the anesthesia also should not take much time. The anesthetic agent should provide adequate analgesia, immobility and muscle relaxation. If you remember, the components of anesthesia does not just include loss of consciousness, but it also includes analgesia, muscle relaxation. So an ideal anesthetic agent will give good analgesia, it will produce immobility, and it will produce good muscle relaxation. An ideal anesthetic agent should be non-inflammable and non-explosive. There should be a wide margin of safety, so it should be a safe drug. Little increase in the dosage should not produce any side effects. It should be potent. That means a small amount of the drug should be able to produce a good anesthetic component. The drug should be cheap, stable and easily stored. Rapid adjustment of depth of anesthesia should be possible. As we saw the stages of anesthesia, it should be easy to shift from one stage to the other faster. That should not take much time. And lastly, an ideal anesthetic agent should not react with rubber tubing or soda lime. So the anesthetic tray, which I will show later, there are a lot of tubes or pipes which are there, which are made of rubber. Now the anesthetic agent should not react with the rubber tubing. It can corrode. If it reacts, it can corrode the rubber tubing. Also, the anesthetic tray contains soda lime for trapping the carbon dioxide and converting it into bicarbonate. So the anesthetic agent should not react with this soda lime as well. Now let's look at the classification of general anesthetics. So they are broadly classified into inhalational agents and parenteral agents. The inhalational agents are further classified into volatile liquids and gas. So amongst gas, we have nitrous oxide, and the volatile liquids include halothane, isoflurane, desflurane, sevoflurane and ether. Please remember, ether is not used anymore because it is highly inflammable. Therefore, the use of ether has declined substantially. Amongst the parenteral agents, you have inducing drugs or general anesthetics which are used just for inducing or starting the anesthesia, that is thiopenton, propofol, etomidate. And then you have slow acting parenteral drugs like benzodiazepines, that is diazepam, lorazepam, midazolam, ketamine, and opioids like fentanyl, alfentanyl, sufentanil and remifentanil. So again, if we just look at the classification, you have inhalational agents and you have parenteral agents, that is drugs which are given through the IV route. Amongst the inhalational agents, you have a gas like nitrous oxide, you have volatile liquids like halothane, isoflurane, desflurane and sevoflurane. Amongst the parenterally administered compounds, you have inducing agents or drugs which are given to start the anesthesia like thiopenton, propofol and etomidate because they are rapidly acting drugs. And you have slow acting drugs like benzodiazepines like diazepam, lorazepam, ketamine and opioids like fentanyl, alfentanyl, sufentanil, and remifentanil. So moving on to the first group, the inhalational agents. Okay. So the two most important drugs, or the prototype drugs in inhalational agents, are halothane and nitrous oxide. As we saw, halothane is a volatile liquid, whereas nitrous oxide is a gaseous general anesthetic. Now the advantage of nitrous oxide is it has a very wide margin of safety. So it is considered a very safe general anesthetic. Whereas halothane, the margin of safety is not wide. So we'll have to be careful, or we have to monitor the dose of halothane that is given. If you look at the potency, then halothane is a very potent anesthetic, whereas nitrous oxide has poor anesthetic ability. So to attain the normal general anesthesia, you have to give a large amount of nitrous oxide. However, analgesic property of nitrous oxide is excellent, whereas halothane has poor analgesic capacity. Muscle relaxation is poor with both halothane as well as nitrous oxide. If we look at the side effects, then the main problem with halothane is it produces cardiac depression. So it can cause reduced heart rate, reduced BP. It can lead on to arrhythmias in the heart. Higher doses can cause hepatotoxicity, and in certain individuals, halothane can produce a symptom called as malignant hyperthermia, which is characterized by abnormally high body temperature. This happens because certain people have an abnormal form of ryanodine receptor, RYR, ryanodine receptor. Now, those people that have this abnormal ryanodine receptor in the sarcoplasmic reticulum, when halothane is administered to such people, it leads to abnormally high amount of calcium being released from the sarcoplasmic reticulum because of the activation of these ryanodine receptors. Once high amount of calcium is released, that leads to contraction, muscle contraction, that causes abnormally high body temperature. So that is what is malignant hyperthermia, which is one of the important side effects with halothane. In nitrous oxide, although it is a safe anesthetic agent, but in very high doses it can cause leukopenia and megaloblastic anemia. Halothane is preferred in asthmatics because it produces bronchodilation. So therefore, in asthma patients, halothane will be a better option as compared to nitrous oxide. Now, if we look at all the volatile liquids, that is halothane, isoflurane, desflurane, and sevoflurane, amongst them, halothane has the slowest induction and recovery, whereas with the other three drugs, the induction is rapid. That means the person gets anesthetized very soon, and the recovery is also rapid. That means the person gets out of the anesthesia also pretty early. Halothane, as we saw in the previous slide as well, is a poor skeletal muscle relaxant, whereas all the other three, isoflurane, desflurane, and sevoflurane, have good skeletal muscle relaxation properties. The side effects of halothane that we saw, it produces cardiac depression, arrhythmias, hepatotoxicity, and we also saw it has the propensity to cause malignant hyperthermia. Isoflurane has been shown to cause respiratory depression, especially if the dose exceeds normal dose. Desflurane does not produce a smooth induction. There it irritates the air passage. That is the side effect with desflurane. And the problem with sevoflurane is it's an expensive drug. Okay, so it cannot be used in all kind of hospital settings. Other problems with sevoflurane is it cannot be given with soda lime because it has an action, or it reacts with soda lime. It has a chemical reaction with soda lime. So we have to use it carefully. And desflurane, the advantage is it has a very short recovery period. So amongst these, if we see, desflurane provides the best alternative amongst the volatile anesthetic agents, followed by sevoflurane, isoflurane, and halothane in that order. Now in the hospital, if we see, normally halothane, isoflurane or sevoflurane, they are combined along with nitrous oxide. Now the basis for combination is, firstly, nitrous oxide rapidly diffuses, whereas halothane or isoflurane diffuses poorly. So if you just give halothane or isoflurane, because the diffusion is poor, it will take a longer time to diffuse into the lungs alveoli, and also you need a higher dose. But if you give with nitrous oxide, then together it produces something called as a second gas effect. Now the second gas effect is seen with nitrous oxide, wherein when nitrous oxide is given along with another volatile liquid or gas, because nitrous oxide rapidly diffuses into the alveoli, along with it, it will also take the second gas, which can be halothane or isoflurane. It will also take the second gas along with it, because of which the second gas also will have a good diffusion. So to repeat it again, second gas effect is normally seen with nitrous oxide. Since nitrous oxide has good diffusion along the alveoli in the lungs, if you give another volatile liquid or a gas along with nitrous oxide like halothane or isoflurane, when nitrous oxide diffuses from the bronchioles into the alveoli, it will also take the second gas, that is halothane and isoflurane, along with it into the alveoli. So the advantage of the second gas effect is reduced dose of the second gas is required, because even if you give a small dosage of the second gas, it will diffuse into the alveoli and produce the anesthesia. And if the dose is reduced, automatically the adverse effects also will be reduced. So that is the main reason why nitrous oxide is combined along with halothane, isoflurane, sevoflurane, etc. Next, let's move on to the inducing agents. So as I told you, inducing agents are drugs which have a very rapid onset of action, because of which they will produce anesthesia very soon. They act also for a very small period, because of which the recovery also is very soon. So the most important inducing agent is thiopenton sodium. Thiopenton is an ultra short acting barbiturate. So it is used in the induction of anesthesia, and it is also used in the treatment of status epilepticus. Status epilepticus, as we know, is an emergency situation wherein there is repeated seizures that happen. So you need a drug which will calm the brain immediately in a very short duration of time. Hence thiopenton sodium is useful in status epilepticus. Now why is this thiopenton sodium a rapid acting drug? That is because it is highly lipid soluble. Because it is highly lipid soluble, it can cross the blood-brain barrier very fast and enter into the CNS, producing its action. Okay. So the onset of action is very fast, that is, it starts acting within 15 to 20 seconds. And because the onset of action is faster, and because it is highly lipid soluble, because of which redistribution happens, and the drug, the faster it gets into the CNS, the faster it gets out of the CNS into the other, it gets redistributed into the other body tissues, therefore causing a short duration of action. So the onset of action is rapid, action starts in 15 to 20 seconds, and the duration of action is also very short, less than 10 minutes. That is because there is redistribution of the drug from the CNS into the other tissues of the body. Now the problem with thiopenton sodium is it can depress the respiratory center, the vasomotor center, and in higher doses it can depress the myocardium as well, reducing the heart rate and the blood pressure. Moreover, thiopenton sodium is a poor analgesic and a poor muscle relaxant. So although it induces anesthesia very fast, the other properties of a general anesthetic, that is analgesia and muscle relaxation, are not done very well with this drug. The side effects of thiopentone sodium include it causes laryngospasm because it's a poor muscle relaxant. It actually produces constriction of the larynx, causing laryngospasm, and it can also produce shivering and delirium during recovery from the anesthesia. The second drug is propofol. Propofol, again, because it is an inducing agent, it rapidly produces induction within 15 to 45 seconds, and the recovery also is very rapid. Now, because propofol has an action of less than 10 minutes, that is why it is most suitable for outpatient surgical procedures, where you want the patient to be surgically treated, or if you want to conduct a surgical procedure and you want the patient to return back to his home the same day. In that case, propofol is a very good anesthetic agent because it will rapidly produce induction of anesthesia and the recovery is also rapid. Therefore, the person will not have any delay in recovery and will not have sedation or any other side effects. Moreover, post-operative nausea, vomiting are very rare with propofol. So, the patient need not stay in the hospital for an entire day or more for recovery. The only problem with propofol is if given in a higher dose, it can cause respiratory depression and fall in BP. Hence, the dose has to be monitored. Another problem with propofol is when you are injecting it intravenously, there can be pain on injection. Therefore, first the area is anesthetized using lignocaine, which is a local anesthetic, and then you inject propofol. The next inducing agent that is important and commonly used is called ketamine. Now, ketamine produces a type of anesthesia called dissociative anesthesia. So, dissociative anesthesia means that the person is anesthetized, the person does not feel the pain. However, the person is still conscious enough and he is dissociated from his body. That means the person has not totally lost consciousness, but the person is not able to feel the surgery happening. So, the advantage of dissociative anesthesia is the person is still able to breathe on his own. So, you do not need to intubate the patient, or you do not need to give artificial respiration to the person. The person can pretty much breathe on his own. You just have to monitor the breathing while the surgery is going on. Meanwhile, the person is anesthetized, there is analgesia present, and there is amnesia as well. The person will not remember the procedure that is happening even though he is conscious. So, this is what is called as dissociative anesthesia, which is produced exclusively with ketamine. So, what ketamine does is it blocks NMDA receptors. Now, NMDA receptors release glutamate, which is a excitatory neurotransmitter. So, ketamine acts by blocking NMDA receptors in the cerebral cortex, therefore reducing excitatory neurotransmitter or glutamate in the brain. Ketamine has good analgesic effect. The main problem with ketamine is it causes sympathetic stimulation. Therefore, it can produce a rise in heart rate and a rise in blood pressure. Because of the sympathetic stimulation, ketamine causes bronchodilation. Therefore, ketamine can be used in asthmatics. Remember, halothane was another anesthetic agent which can be used in asthmatics. Ketamine also can be used in asthmatics. Other problems with ketamine is it increases the intracranial pressure and it can cause hallucinations during recovery. So, ketamine, although is a good anesthesia wherein the person is able to breathe on his own and does not require artificial respiration or intubation, but it has the problems of sympathetic stimulation, it can increase intracranial pressure and it can cause hallucinations during recovery. The next inducing agent is fentanyl, which is an opioid analgesic. So since this is mainly an analgesic, its anesthetic property is not very marked, not very good. Therefore, it is mostly used as a supplement with other agents. You do not use it individually as an anesthetic agent. The problems with fentanyl is because it is an opioid, it can cause marked respiratory depression. There can be fall in blood pressure and heart rate. However, the advantage of using fentanyl is there is a specific antidote available which can be used for reversal of fentanyl, that is naloxone. So naloxone, which is an opioid antagonist, is used for the reversal of action of fentanyl. Now there is a term called neuroleptic analgesia, wherein we combine an opioid analgesic like fentanyl along with a neuroleptic drug like droperidol. So fentanyl is an opioid which produces excellent analgesia. Droperidol is a neuroleptic drug which produces sedation and can also produce amnesia. So the combination of these two drugs will provide good anesthesia, good analgesia and good amnesia. So smooth induction and recovery. Adverse drug effect will be less since the individual dose of each drug is reduced. The only problem is there is no muscle relaxation which is seen with these drugs, so muscle relaxant has to be separately given. The next group of drugs are benzodiazepines, which are also parenteral anesthetic drugs, and amongst the benzodiazepines, diazepam, lorazepam and midazolam are commonly used as general anesthetics. They are slow acting drugs, so they cannot be used as inducing agents. Okay, and another problem is when you give large dose of this drug, that delays the recovery of the patient and it prolongs the amnesia. So that is why benzodiazepines are not commonly used as inducing agents, because it delays the recovery, it is slow acting and it prolongs the amnesia. They also have poor analgesic effect, so an analgesic has to be given separately. However, the advantage of benzodiazepine is they do not cause any post-operative nausea and vomiting, and like opioids, benzodiazepines also have an antidote, specific antidote, so the action of benzodiazepine can be reversed by flumazenil. That is the advantage. Now let's move on to another term called conscious sedation. So as the name suggests, there is sedation, which means the state of CNS depression is produced. However, the person is still conscious. Okay, so drugs that are used to produce a state of CNS depression but not unconsciousness. So we said that general anesthesia is one where the person loses consciousness. However, there are certain drugs like diazepam, propofol, nitrous oxide, fentanyl, wherein the person will be in a state of CNS depression but he or she will not be unconscious. So the advantage of this is the person can breathe on his own, he can maintain a patent airway and he is able to respond to commands. Therefore, conscious sedation is much safer than the normal general anesthesia. Okay. The next thing that we will look into is pre-anesthetic medication. Now, remember, when we talk about general anesthesia, it is not a very pleasant experience for patients and it has a lot of risks involved with it, because we are sedating the patient, we are making the patient unconscious, and because of which the person is not sometimes able to breathe on his own. Okay, so we are taking care of the respiration, because of which there are many other problems that can happen. Therefore, in modern day, the anesthesia has to be associated with a pre-anesthetic medication. So pre-anesthetic medication consists of a set of drugs which are given before administration of anesthetics. So the main aim of pre-anesthetic medication is to make the anesthesia more pleasant and safer for the patient. So what are the objectives of pre-anesthetic medication? First thing is to reduce anxiety and apprehension. If the person is calm, then the induction of anesthesia will be much more faster. The second objective is to prevent vagal bradycardia and reduce salivary secretions. This is important because if vagal bradycardia happens, then sometimes the person can go in for asystole and arrhythmias, which can be problematic, and salivary secretions need to be reduced, especially when we are intubating the patient. So it is important so that the person does not aspirate his own secretions. The next important objective is to relieve pre and post operative pain. As we saw, many of the anesthetic agents do not provide good analgesia. Therefore, you have to give certain drugs along with the anesthetic agents to give good analgesic effect. Certain anesthetic agents can produce nausea, vomiting. So, for antiemetic effect, we have to give certain drugs. Now, this whole process of general anesthesia and the stress associated with it can lead to increased acid secretion and leading to stress gastric ulcers. So, we have to prevent that. And especially suppose if a patient comes for an emergency surgery, okay, and the patient's stomach is not empty, we want to increase or fasten the gastric emptying. Okay, this is especially applicable before emergency surgery. So to hasten the gastric emptying also certain drugs are given. So reducing the anxiety and apprehension is done by benzodiazepines, by giving benzodiazepines, diazepam, lorazepam, midazolam. Atropine or glycopyrrolate, these are anticholinergic drugs which prevent vagal bradycardia and they reduce the salivary secretions. Opioid analgesics like fentanyl, tramadol, NSAIDs, these are drugs which are used to relieve pre and post operative pain. Antiemetic drugs that are used are metoclopramide, domperidone, ondansetron. Ranitidine and omeprazole, they prevent acid secretion and prevent development of stress ulcers. Again, metoclopramide or domperidone, since they are prokinetic agents, they increase gastric emptying before emergency surgery. So these are the drugs which comprise of a set of drugs called as pre-anesthetic medications, which are very important drugs which have to be given before administering anesthesia to the patient. So if we look at the overall anesthetic protocol, you first start with giving the pre-medications, okay, which will help in reducing the anxiety, for analgesic effect, for reducing the nausea, vomiting, for reducing the salivary secretions, etc., as we just saw. So pre-medication is important. Now the anesthesia per se is divided into two things. Okay, so we use an inducing agent, we use a maintenance agent. Now this is important because inducing agents, as we saw, thiopental, propofol, these are drugs which start the anesthesia very soon, but then the problem is that their duration of action is also very less than 10 minutes. So if we just want to give this thiopental or propofol as an anesthetic agent, every 10 minutes we will have to keep on injecting the drug. Now that will again have its own side effects. Therefore, the short acting drugs like thiopental, propofol, these are only used to induce or start the anesthesia. Once the anesthesia is started with these drugs, then the next thing is the maintenance. Maintenance is done mostly by these volatile liquids like isoflurane, halothane, along with nitrous oxide. Okay, so this is how the anesthesia is given. Now along with this, a skeletal muscle relaxation has to be given to abolish the reflexes. Analgesia, of course, is a part of the pre-medication. Plus you also give analgesics during the surgery and post-operatively as well. Other drugs which are used as part of the anesthetic protocol are drugs to reverse the neuromuscular block it, and to reverse the residual effects of opioids, that is naloxone, which is its specific antidote, and flumazenil, which is the specific antidote of benzodiazepines. So this is the anesthetic tray that I was talking to you about. So if you see, it has a BP apparatus. Okay, these are the cylinders that you see. These are the cylinders that contains the gases or the volatile liquids, so the maintenance agent, and these cylinders are color coded. So meaning to say that depending on the color of the cylinder, we know what is the gas or the volatile liquid that is there inside. Okay, so here you see there are two cylinders. So the cylinders, one of the cylinder will be an oxygen cylinder and the other will be a nitrous oxide or a volatile liquid cylinder. And this is a bag and mask, which is used for providing respiration to the person. This is the soda lime. So the carbon dioxide flows into the soda lime chamber where it is converted into bicarbonate, and there is a BP instrument here as well, which is used to continuously monitor the blood pressure of the patient during the surgery. So a brief look into the nursing implications of general anesthetics. So the most important thing is the anxiety of the patient has to be reduced. That is, you have to continuously keep on reassuring the patient, and administering diazepam the previous night so that the person has had a good sleep is important. So once the person is not anxious, the induction of the anesthesia becomes much smoother. Second thing is, after the procedure, the person has to be encouraged to breathe deeply so that the partial pressure of oxygen or the SpO2 level of oxygen rises in the body. And the next thing is, during the procedure and after the procedure is over, it is important to monitor the patient for the complications of anesthesia, like any nausea or vomiting, any respiratory depression the person might get into, if the heart rate is falling or increasing, or any abnormal change in BP. All these things have to be carefully monitored during and after the anesthesia is given. So this is all about general anesthetics. The most important things that you have to know in this chapter is pre-anesthetic medication is important. You also have to know the classification of general anesthetic agents and the properties of the inducing agents, as well as halothane and nitrous oxide is important. So thank you.